In the pediatric patient population, I think this approach is, in our view, suited for all patients who undergo a haploidentical transplantation, which would be otherwise at high risk of developing graft versus host disease, especially in children. Graft versus host disease, either acute or chronic graft versus host disease, can be a very serious disease which has quite an impact on the quality of life of patients, especially if they develop severe chronic graft versus host disease. So we in our center, we perform all these haploidentical transplantations using the ex vivo T-cell depletion, because in our opinion and in our experience, this is the only reliable method to prevent graft versus host disease in the patients. This is not only for malignant diseases, which we treat, like acute lymphoblastic leukemia, myeloid leukemia, myelodysplastic syndromes, but also for patients with non-malignant diseases where transplantation can be often a cure, especially also genetic diseases, inherited hemoglobinopathies like thalassemia, sickle cell anemia, where transplant is really a cure for these patients. A lot of these patients do not have donors, HLA-matched donors, either siblings or from the registries. So we increasingly use the haploidentical transplantation for those patients, and especially in patients with non-malignant disease, graft versus host disease is not necessary at all and should be prevented by all means. In some of the malignant patients or malignant diseases like leukemia, one can argue a little bit of graft versus host disease might have an anti-leukemic effect. But in the non-malignant diseases, graft versus host disease is not necessary and should be avoided. In our experience, the ex vivo T-cell depletion is the only reliable method to prevent graft versus host disease in those patients. The major challenges are the establishment of the T-cell depletion technology at various centers, and in our phase 1/2 trial, which was a multi-center trial across Germany and one center in the Netherlands, this was done very successfully. All the manufacturing centers performed with the same efficacy. We did inter-center controls and sent around samples to check each other. And based on the robustness of the TCR alpha beta depletion, all centers had a very similar efficacy of T-cell depletion, which is of course the most important point in doing a multi-center trial with various manufacturing centers. And that went very well. All the centers were very adherent to the clinical protocol. And so far, I think the possibility of performing further multi-center trials are very good, especially since the method is can well be distributed among other centers. And it's easy also to teach other centers to do this T-cell depletion with this technology. It's not very complicated, and the technicians working in the GMP labs or in the labs who are doing this technology, they can learn this very fast.